Well, thank you for the kind introduction. It's a pleasure to be here to talk about expanding access to HIV testing and treatment to improve patient outcomes. So I'll leave my disclosures up for a moment. Abbott's been on the front lines of HIV testing for some time, having developed the first FDA-approved assay to diagnose and test for HIV back in 1985. You can see in this picture in the left-hand side of the screen the team that accomplished that goal. On the very left is George Dawson, who actually worked in our team until very recently. And obviously, we need to continue to make tests accessible, robust, that work no matter where a test is performed or an infection is acquired. In a similar way, in 2020, we had to spring into action to develop many diagnostic tests to fight the SARS-CoV-2 pandemic. HIV diversity is always front of mind when you're developing diagnostic tests. You see here in this graphic that there's been 4 zoonotic transmissions into the human population over time. On the left-hand side, the most common group M came from a zoonotic transmission from a chimpanzee, as did group N, whereas group P and O were transmitted via gorilla. And you can see the length of these lines illustrates the amount of genetic difference or distance between these strains. And you can see that with group O, there's a large distance between group O and group M, with about 50% similarity at the subtype, at the amino acid level rather. And with 45 primate species, there's always the potential for ongoing zoonotic transmission. So we have to be cognizant of these starting points, these potential for introductions of HIV into the human population from primates, but also how the virus then evolves in humans once it gets into the population is equally as important. And you can see, as we talked about, the starting point of the different animal species where the virus can be introduced into humans is like a founder effect. But also when it's in the person, the evolution starts immediately in response to the immune system or therapeutics that may be administered or other factors. And this causes the virus to change over time. And just because you're infected with one strain of HIV does not mean that you can't be infected with a second. And that leads to what's called recombination, where 2 different strains of HIV are present in the same cell, and chunks of the viral genome can break off and recombine between these 2 strains, creating kind of like a mosaic, as you see in the bottom of this slide. And circulating recombinant forms, as they're known, are these mosaics that are found in more than one person that are not linked together, whereas unique recombinant forms are these mosaics found only in one individual or directly linked to that individual. In this slide, we see the level of genetic diversity of HIV compared to SARS-CoV-2. We're all very familiar with SARS-CoV-2 coming out of the last pandemic, and you can see the relative, very, very minuscule amount of diversity in SARS-CoV-2 when compared to HIV. On the right-hand side, you've got SARS-CoV-2 that has to be blown up to be even visualized from almost 600 people, whereas the amount of genetic diversity in HIV group M from 229 individuals is illustrated on the left. And this, explains the level of complexity and difficulty and the challenge that we face in developing diagnostic tests, therapeutics, and vaccines that continue to work for HIV over time as this virus evolves in this way. Again, comparing HIV to influenza, on the left-hand side, you can see the global strains of H3N2 collected in 1996 and compared to these sequences longitudinally collected from a single individual over time are very similar. So you can see the amount of total global diversity of influenza in 1996 was very similar to the amount of diversity seen in HIV in a single person looked at over time. When you look further on the right, from a group of individuals, again, a snapshot in time of HIV subtype B, group M subtype B from Amsterdam, a significantly more diverse than influenza. Go further right, and you've got roughly 200 people from the Democratic Republic of Congo, again, all group M, with immense amounts of diversity relative to influenza. So HIV is a very difficult virus to develop diagnostic tests, therapeutics, and vaccines for that will work robustly over time. This is particularly important when you consider the impact that this evolution, this diversity can have on diagnostic tests. The molecular tests that are designed to detect and quantify the amount of virus in an individual depend on primers and probes binding to stretches of the viral genome sequence. So changes in that sequence that might impact the ability of those primers and probes to bind can impact the ability of the test to give off a signal and to do its job. Similarly, on the left-hand side, when we look at serology, we're looking at epitopes of proteins that are based on the sequence of the virus. So changes in that viral sequence can change the epitopes that serology assays need to detect. So keeping this diversity in mind is critical when developing diagnostic tests, and understanding that it's not a stationary target. It is very much a moving target that continues to evolve over time. With that in mind, in 1994, Abbott established its global viral surveillance program that specifically at the time focused on HIV, but other pathogens such as viral hepatitis were added over time. And this program was established to look at how the virus was evolving over time and diverse populations around the world, to monitor for the emergence of new strains, to characterize these specimens and look for discordant diagnostic test results versus the clinical status. And it really is the bedrock and foundation of how our diagnostic tests are developed. And panels of these very diverse strains are used for regulatory submissions to demonstrate to regulators that our tests continue to stand up to the diversity of this virus over time. And it gives our customers and patients and anyone who gets an Abbott diagnostic test for HIV the confidence that that test should reliably work regardless of where the test is performed or where the infection was acquired. And we've made a number of discoveries through this program, which I will discuss in later slides. And we've collected over 100,000 rare samples that are in our biorepositories and published over 230 peer-reviewed publications as an illustration of how transparent the program is. We share what we've learned, we upload the sequence and share this through peer-reviewed publications. So as I mentioned, the program, the viral surveillance program, has been in place for 29 years. And this slide really highlights some of the more recent news. It's not that nothing happened between 1994 and 2009, but we're focusing on the more recent history. In 2009, when we added hepatitis B, in 2011, where we identified only one of 2 cases of HIV group P ever discovered and characterized in the world was discovered by this program. Similarly, in 2017, we identified many diverse strains of HIV and actually hepatitis B and HTLV in Cameroon, and in the Democratic Republic of Congo also, where we found a HIV group M sample, which was characterized and actually enabled that subtype to be officially named as the first new HIV subtype to be named in almost 20 years. So these are some examples of highlights of some of the work that's been done through the Global Surveillance Program, focusing primarily on HIV. Obviously, in 2020, the SARS-CoV-2 pandemic occurred, and we rolled SARS-CoV-2 into our surveillance program, which was very useful in terms of ensuring the diagnostic tests we made for that virus also stood up to the test of evolution and diversity that that virus threw at us. I mentioned previously that the Global Surveillance Program had identified one of only 2 HIV group P infections seen in the world. And the index case was a 62-year-old Cameroonian woman who had been infected in Cameroon was feeling unwell when she moved to France, was screened by a physician who did a blood draw. There was no detectable viral load in the sample when it was tested with the Roche Cobas Monitor 1.5 test. But when it was tested with the Abbott real-time viral load assay and subsequently with the Architect HIV combo test, it was positive. The sample was sequenced and identified as a novel zoonotic transmission, a group P. When the global surveillance program went back and screened samples that we had collected over time in Cameroon, we also identified the second case of HIV group P, again in Cameroon. The program enables us to pull together a very diverse panel that's illustrated in this slide here, consisting of all the different subtypes, many different very diverse circulating recombinant forms that have been collected in many countries around the world. And the program has also identified more than half of the known group N infections. And as I've mentioned in the previous slide, one of only 2 group P infections ever described in the world, and over 200 HIV group O infections. So this work is ongoing to ensure that our HIV viral load tests, serology tests, rapid tests continue to work no matter where the tests are performed or how this virus is evolving. In India, we worked with our collaborators at YRG Center for AIDS Research and Education to look at HIV and hepatitis diversity in the country, studying retrospective samples that were collected around the country. Over 750 HIV samples were sequenced. These are samples with sufficient viral load to sequence. What was interesting in this study was that we identified many recombinants, but also that the variants or the strains that we saw mapped to the drug trafficking routes coming from the east in the Golden Triangle and the west of the Golden Crescent, I believe, down through the 2 sides or the different coasts of India, and Delhi was kind of a merging or a melting pot of these strains, so that you could almost track the introduction of these strains and their movement through the country based on the drug trafficking routes. In the Democratic Republic of Congo, as I mentioned, we identified the HIV group M subtype L that enabled that to be named. We also found a variety of HIV subtypes, circulating recombinant forms. We're able to look at the prevalence of viral hepatitis in that country. And we also found a large number of cases. Now, this was a cross-sectional study, not a longitudinal study, but a large number of cases where the patients were antibody positive but had very low or non-existent viral load, suggestive of elite suppressors or elite controllers, even though there was no drug on board. Around roughly 4 to 5% of these cases, these samples fit that profile, which was very unusual and would warrant and require additional follow-up to investigate it further. Our work in China, working with blood transfusion services, we looked at the ability to accurately diagnose HIV with CMIA, such as the Architect HIV combo or Alinity HIV combo assay, or EIA assays, either 1 or 2 used in combination, with over 2,000 specimens. And in this study, the CMIA assay performed better than either 1 or 2 ELISA assays, better concordance to Western blot with fewer false positives or false negatives. And in our sequencing studies with NCCL, where we looked at large volume samples for HIV, Hep B, and Hep C positives identified through the blood transfusion service, we identified interesting African CRFs, CRF02 and 06 in the Shanxi province, which were not known to be circulating in that population. We talked about viral evolution, viral diversity in the context of HIV, as it is incredibly important to ensure that diagnostic tests, therapeutics, and vaccines continue to work. But viral diversity is really the driver of new pandemics. As we saw with SARS-CoV-2, it was a divergent coronavirus that was introduced into the human population. And also with HIV being multiple zoonotic transmissions from primates, from non-human primates. So we need to be cognizant of how our known pathogens are evolving, but also how viruses are evolving to be future threats, potential new pandemics, and to be ever vigilant of this. We've seen in the recent past Ebola, Marburg, Mpox reemerging and causing huge problems around the world. Zika ripped around the world 10 years ago, causing massive problems. There's a huge amount of illness that goes undiagnosed on a regular basis. 30 to 50% of gastroenteritis, 50 to 70% of meningitis and encephalitis goes undiagnosed. What is causing these illnesses? To meet this challenge and to try and understand this, Abbott has developed a first of its kind Pandemic Defense Coalition, a network of experts working to try and identify interesting cases which could be an emerging or re-emerging pathogen, and to try and ring fence these outbreaks to try and prevent the next pandemic. How it works? Well, it all starts with a patient sitting in front of a physician unable to make a diagnosis, but in this case, the physician is educated enough to identify these interesting cases or trends in his patient population, to collect the appropriate samples, to get these samples to an expert network of labs that have been established around the world through this program, so that they can have very sophisticated diagnostic testing and other forms of testing performed on them to try and understand if there's a re-emerging or emerging pathogenic threat. As I mentioned, it starts with the case where there's no diagnosis, fitting a case definition or a set of criteria that warrants it to be triaged into the program, where it undergoes very sophisticated sequencing, bioinformatics techniques to try and understand what could be in that sample and making that person sick. There are many networks out there who are also trying to do this type of work, but I think where the Abbott Pandemic Defense Coalition is unique is that in addition to identifying novel pathogens and democratizing the expertise and techniques that we've developed over the decades, we also are able to rapidly react to what we identify in those samples, to quickly develop molecular serologic tests, either for the core lab or for rapid diagnostic testing, that can be then deployed through our network of partners around the world and enable them to conduct the kind of additional heavy lifting, the additional investigation into what we've discovered to see if it is truly a pandemic threat or is it a one-time zoonotic spillover, to assist the public health community and provide them with additional information and tools to try and anticipate threats and hopefully prevent the next pandemic. The network, or the coalition, now comprises of 20 sites in 17 countries on 5 continents. They're shown here with the great diversity spread out over South America, Africa, Asia, and the United States. This network gives us great coverage and works in key populations, looking not just for emerging new pathogens, but also trying to have a positive impact on existing epidemics and pandemics like HIV and viral hepatitis. Capacity building and training is critical to this program, and you would imagine that we would focus primarily on the development of scientists and lab capacity. As you see in the central panel, we do a lot of work in building the next generation of virus hunters, PhD students in different institutions, our partners coming to our labs and learning how we go about virus discovery and pandemic prevention. In addition to that, we've focused heavily on bioinformatics, building bioinformatic pipelines, training people in the use of these tools. But the most exquisite bioinformatics pipeline, the best trained lab scientists using the most cutting edge lab technique, is not very effective if we don't get the right samples to those labs and through those pipelines. So the Abbott Pandemic Defense Coalition has focused holistically on also training the next generation of field epidemiologists through a partnership with the Task Force for Global Health and their TEFINET program. We're going into our 3rd year of fellowships where we provide full year fellowships for up to 10 awardees working to hone their skills in epidemiology and working in infectious disease in areas related to emerging, re-emerging, or new pathogenic threats. So the take-home messages today are the HIV continues to evolve. New mutants occur on a daily basis, and we need to be monitoring for these because they can have an impact on how the virus is transmitted, how it's diagnosed, and how it's treated. They can also impact the accuracy of diagnostic tests. So this is reinforced every day, and we recommit to the global surveillance program and our ongoing research to make sure that our diagnostic tests work regardless of where they're performed or where an infection is acquired. And also to monitor the trends of emerging pathogens globally to make sure that we're poised to respond and react through the Abbott Pandemic Defense Coalition and our global collaborations where we tackle not just new emerging or re-emerging pandemic threats, but the ones that are ongoing every day, viral hepatitis, HIV. We need to remain focused on these ongoing threats that kill millions of people every year so that we can have a positive impact. And on that note, I'll hand it over to Professor Solomon to talk about his experience in India.
Thank you, Gavin, for that comprehensive overview of the complexity associated with the development of diagnostic tests, especially for viruses like HIV that are rapidly diverging. I just want to start by saying that identifying and building diagnostics is the first step, but unless we can get the diagnostics into the hands of the people who actually need them, we really aren't going far in terms of making an impact on the pandemic, whether it's HIV or whether it's SARS-CoV-2 or whatever or viral hepatitis. These are my disclosures. I want to start by just reminding everyone of the UNAIDS 95-95-95 targets. So UNAIDS has set these ambitious targets to be achieved by 2030 in order to achieve HIV/AIDS epidemic control, wherein 95% of people living with HIV should be aware of their status. 95% of those who are aware of their status are on sustained antiretroviral therapy, and 95% of those on therapy achieve viral suppression. So where are we now? So this shows you the growth between 2015 and 2022, and you can see we have definitely made progress. But as you can see, the biggest gap still is in that diagnostics. It's about 9% of the people aren't aware of their status. Because if you can find them, the linkage to care, getting people on treatment, keeping them on treatment, getting them suppressed is much easier. But also important to note is like the progress is not even across. So most of that data, as most of you recognize, comes from sub-Saharan Africa, which bears the brunt of the HIV epidemic, with the majority of people living with HIV living in that particular region. But if you step outside that region and go to India, or you go to Southeast Asia, or Central Asia, or Ukraine, or Eastern Europe, you see a completely different picture, especially among key populations such as men who have sex with men and people who inject drugs, where only about 50% of the people are actually aware of their status. So if only 50% are aware, then we really have a long way to go in terms of finding people, then linking them to care, then making sure they stay in care and they get virally suppressed. And if you really are serious about achieving HIV/AIDS epidemic control by 2030, it's not enough to focus only on sub-Saharan Africa or only in high-income countries. We need to be finding solutions to reach the most vulnerable populations and the most vulnerable communities across the world. So how do we get there? I think the easiest thing is index testing, which is what it's called these days by PEPFAR and other large programs globally, but it's the same as contact tracing. So these are data from an index testing program across 2 Indian states, Maharashtra and Telangana. So what it essentially does is if someone is diagnosed with HIV, we ask them, who have you had sex with, or who have you shared needles with, whom you might have placed at risk, get those names, what those are the contacts elicited, then contact the contacts and ask them, can we bring you in for screening? Then you screen the contacts and then you test them and then you link them to care. So you can see that over like a 3-year period, we screened about 20,000 people using this index testing approach, and about 20% of these individuals were found to be living with HIV. And almost 90% of them were linked to antiretroviral therapy. So again, this is a very efficient strategy because you essentially are focusing on people who are positive and getting their networks in. Well, we know that most people don't go to healthcare facilities. Like most of us don't go to a doctor, especially if you go to a low and middle income country setting. We don't go to a doctor until it's too late. So how do we reach populations who don't come into a healthcare facility? And there's another approach called social network strategy. You're all familiar with Facebook or how it works, and you connect with different people. So it's a similar approach which we use for HIV screening or hepatitis screening, or screening for any infection for that matter. So the way it works is you find two influential individuals from the community. In this case, we were working with people who inject drugs in the city of Kanpur. We give them two coupons, say go out, give it to any other two people who inject drugs in Kanpur, have them come in. If they come in, you'll get an incentive of 50 rupees, which is less than $1, if they complete all their study procedures. So they go out, give it to two people come in, you repeat the process with them. So the two becomes four, and then in that gradual process, people start referring each other into the program by themselves. And in Kanpur, for example, over a period of 130 days, we recruited about 1,000 people who inject drugs. And as you can see from all the yellow and the green and the orange on this figure, a lot of HIV and hepatitis C in this population. But I think what was really striking was, besides with the prevalence, almost none of them were aware of their status. So this really is like a very powerful tool where you can leverage the network connections to bring people in, especially populations like people who inject drugs or men who have sex with men in several low and middle income countries where these behaviors are actually criminalized and punishable by law. This is a very effective strategy in reaching these people. The other thing we also saw was integrated screening is efficient. So the way programs are structured globally is like you have an HIV program, you have a TB program, you have a viral hepatitis program. But people who inject drugs, for example, are at risk of HIV. They're also at risk of viral hepatitis at the same time. So this shows you what it cost us to find one person who was unaware of their HIV status. And it ranged anywhere from $51 to $5,600, depending on which city you were working with, and was driven primarily by the HIV prevalence. And similarly, if you look at hepatitis C, it ranged anywhere from $33 to $663 to find one person who is infected with hepatitis C. Obviously, that's going to be a lot lower because the prevalence is much higher among people who inject drugs. But I think what was striking was, if you integrated the hepatitis C within the HIV program, the additional cost would only be $10. Right? Because if you think about programs and what the biggest cost in most programs, it's bringing people into a facility. Once they're in the facility, the cost of additional screening is minimal. For example, a rapid hepatitis C test probably costs like $1. Screening for diabetes probably costs less than $1. So when you have people in healthcare facilities, it's critical that we start doing a horizontal integration where we start screening for multiple diseases, because people are at risk for multiple diseases, whether they're infectious, non-infectious, or respiratory infections. So I think it's critical that we start thinking about integrated screening approaches. We actually attempted a single window model in India where we tried to integrate different services, from HIV prevention to testing to harm reduction to STI management within the same facility. And what we essentially found was, like, bringing all these services together increased the uptake of HIV testing. So the green arrows that are going up show you the absolute percentage point difference at the community level of the proportion of people who inject drugs or men who have sex with men who were tested, was about 31% higher. And this was noted by the government of India, and we've been working with them. It's actually been translated into policy. And the government is using a stripped down version of these integrated care models called one-stop centers as part of the government program that's established 71 such centers across the country, which really has improved access to HIV services for people who inject drugs, men who have sex with men, and the transgender community, who generally get left behind in most of these programs. But that's not enough. Right? So social network strategy, you still bring people into a particular venue. So when we run many of these social network approaches, we find about 30 to 40% of the people, the coupons that go out never come back in. And so we actually explore, like, could we actually take the testing into the field, especially because there are rapid tests, there are self-tests, as Gavin talked about. And so can we find specific locations in the field and take the tests actually to the people versus having the people come to us? And what we essentially found in the city of Patti, which is on the India-Pakistan border among people who inject drugs, was the two stars on the left side of the screen are the places that had the highest HIV prevalence. So we said, let's go there and test. And as you can see from the right side, The gray dots are basically showing you how many people we were identifying per day. And you could see like it was almost double the number of people living with HIV, double the number of people who were HIV dually infected being identified every day. So if you have explosive epidemics or an emerging epidemic, targeting field-based testing to areas where there's like a high burden of HIV is a very efficient way of identifying people, getting them on treatment, and curbing the epidemic even before it takes off. But still, I think even that is not enough, because what's happened, I think most of you are aware, is like there has been a penetration of internet globally, and dating sites like Grindr, Tinder, Planet Romeo are all over the world. And especially during the COVID pandemic, many people switched from meeting partners in physical venues to picking up partners in virtual venues. Right, so I want to present some of the data that we've been implementing in India as part of a PEPFAR USAID funded program. It's called SafeZindagi.in. So it's built around virtual outreach workers, which are essentially young men and women who are in an apartment or in their houses who go online to these different dating websites like Grindr, Tinder, Planet Romeo, because they are very popular even in India. They go there, talk to the clients there, and say, "Do you want to listen? I'm from this NGO. We want to talk to you about HIV, talk to you about risk. Is this something you're interested in?" And if people are expressing their interest, then the whole conversation switches to WhatsApp. I think most of you who've been to any international setting recognize the value WhatsApp has. Almost all communication happens over WhatsApp. So between text messages, audio calls, and video calls, these virtual outreach workers provide education. They ask them, what kind of test do you want? Do you want to go into a facility? Do you want the test to come to you? So they want to go to a facility. We ask them, do you want to pay for the services? Do you want free services? And then do you want to self-test? Do you want someone to come? So really empowering people to make a choice in their whole decision-making process versus saying this is where you have to go for testing. And then once they are screened, if they're positive, we link them to antiretroviral therapy. If they're negative, we link them to PrEP. And then the virtual outreach workers also continue to monitor retention and care. So over the past 4 years, we didn't really do much over the first year. So I would say most of this data is between 2020 and 2023. We reached about 20,000 people. We've blown up the positivity all the way to initiated ART on the right side. So it's like it's the same numbers, it's just like much bigger, so you could see it. We have identified about 1,200 people who were screening positive for HIV. About 80% of them have been gone through the confirmatory testing. But still, I think it's important to note that in this population, we've identified an HIV prevalence of about 5%, right? The general population prevalence in India is about 0.23, 0.22%. So we are tapping into a population that's almost 25 to 30 times at higher risk of HIV infection. And this is a population that really hasn't been reached before in many of these programs. So it really does show that the future is something that we need to be ready for. And I think most of us, even in the US, recognize that DoorDash, Postmates, and Uber Eats are here to stay. So what's going to happen with healthcare? And I feel like as that generation starts growing up, healthcare is going to have to follow suit and switch into a model where services are being delivered to people where they want them, when they want them. And I know there already has been some transition. There are health monitoring watches and devices, but it's just a matter of time before diagnostics also move into that realm. So I did present these 4 different strategies, but even after we use these 4 strategies, we still don't reach some of these people. For example, in Delhi, there was a venue called venue number 40, which was accounting for almost 71% of all the new HIV infections in the city of New Delhi. So Gavin was actually in India, and we visited the venue. And when you walk into the venue, at the front of the venue is this blue shed that you see. But when you go around the blue shed, you see about like 150, 200, 300 people who inject drugs. The HIV prevalence here is about 40%. Mortality is about 30 per 100 person years. We spoke to a couple of them and asked them, why don't you want to go get screened for HIV? Services are free. Or why don't you want to get screened for hepatitis C? Services are free. And these people just looked at me and said, well, you're talking to me about HIV testing, and you're talking to me about screening for another virus. When I don't have food, I don't have a place to take a shower, I don't have a job. So what do you think HIV screening is going to do for me? Which really has made me think about the way we deliver services, because we really are focused on a disease, right? And I think it's about time we transition from the disease to a person and not just the diagnostic side of it, but really looking at the socio-structural determinants, like providing access to housing shelters, referrals for food, legal health support, mental health support, access to vaccines. I think these are things that we way too often just take for granted because it's something that we've just come to think, oh, it's normal. But for many of these people, especially the ones who are extremely vulnerable to infections, whether it's HIV, viral hepatitis, or SARS-CoV-2, these are a luxury. Like I think people were talking about social distancing. I think that the BBC or someone else put this out, like social distancing is an oxymoron in India, just given the volume and the number of people. So many things we take for granted just don't translate into the real world, especially to vulnerable populations. So we need to think about how do we provide services to reach these people who are not being reached by the other approaches that we're currently implementing. I want to end with a couple of examples of how we have started to explore the role of these models. The first one I want to highlight is the MITRA clinic. So this is again funded by USAID and PEPFAR. So we established about 3 such clinics for the trans community. This is one of the first comprehensive clinics for both trans men and trans women in India. And as you can see from these pictures, all our staff were from the trans community, especially in the Hyderabad clinic. So the way we designed the model is that we did have to do HIV and STI services, but we also included gender-affirming care, including laser hair removal, counseling on hormone replacement therapy, helping them with like their identity cards, which are hard to navigate because these require you to go online, fill out forms. For many of these populations, they don't know how to use these computers. And so we have people in the clinic who help them do these different services. So we've registered about 4,000 clients between 2021 and 2023. But what was striking was about half these clients had never been seen before from the existing PI programs. And what was even more striking, actually it wasn't really striking, but made complete sense, was the big driver was access to gender affirming care, being able to talk about their hormone replacement therapy or showing up for laser hair removal. And laser hair removal can only happen one at a time. So when people were waiting for their laser hair removal, we asked them, do you want to be screened for HIV? Do you want to be screened for STIs? And we were able to identify new people. So about 250, about 10% of the people who were coming to 10 to 15% of the people were either known positive or diagnosed as positive, and almost everyone was initiated on antiretroviral therapy once they came into these clinics. The second model I do want to highlight is something we are doing in partnership with Abbott Labs, and thanks to them for the generosity in evaluating a model. Because the other population that does get left behind are these adolescents, especially in vulnerable areas and communities across India. For example, like in the northeastern states of India, there's a lot of drug use and a lot of alcohol use among adolescents or youth in that 15 to 24 age group. And they generally get left behind programs because they can't go to a pediatric program because they don't provide comprehensive harm reduction services. They're too scared to go to the adult program. So we decided to build a youth center. And the main driver here was really giving them access to free Wi-Fi, golf games. So kids would come in there, they would log on to their Wi-Fi network and watch YouTube Reels and Instagram videos, whichever it is, like Instagram Reels and YouTube videos or whatever that is. But that's literally what brought people into these centers. And when they were in there, we offered like counseling services, we offered access to making sure that they get back to school if they had dropped out of school. And we were also able to offer them with HIV testing. And so again, the prevalence was not high in this population, about 17 out of 400 people, so about a 3% prevalence, but still compared to the general population, it still was much higher. And then the last model I want to end with is the Blue Shed itself. So when Gavin and I were there in 2018, I believe, it was pre-pandemic, we said, wouldn't it be awesome if we could turn this Blue Shed into a place where we could offer HIV testing, HIV care, and provide social support to these individuals. So by the time we actually got it, took us 5 years to get it off the ground. It also took a pandemic to actually make us do this, to get the Blue Shed up and running. But the original Blue Shed was gone by the time we could get it up and running. And so in the true spirit of the Blue Shed, it painted as much of this new facility as we could blue, and we called it the Blue Shed Project. For those of you wondering, it's about 500 meters down the street from the original Blue Shed, so it's not really that far off. And we had like routine services. So the picture on the top right is people standing in line for opioid substitution therapy. We had doctors, we had diagnostics, and we had general services, but we were also able to link in haircuts and food and showers in the same venue. Right? And I think that really was a big lesson for us is these services that we always took for granted were a big draw for many of these people. Right? Just to give you some quick numbers, it's about been running for 6 weeks. About 90, like 60, almost 60% of the clients who've been registered are living with HIV. Hepatitis C is almost 75% of the clients. We have about 7 people who are screened positive for hepatitis B and about a little bit for syphilis as well. But I think what was even more striking was almost 80 people were provided with personal hygiene services. We're providing about 120 to 150 meals for people who are coming there every day. So again, this model is not perfect. We don't have everything in here, but we have to start somewhere. We cannot let perfection be the enemy of good. So I think we recognize that there's a lot more that needs to go into this shed. And it really is a true partnership between Abbott, YRG Care, the Delhi State AIDS Control Society, and multiple community-based organizations, all of whom had input. For example, the harm reduction services comes from the Delhi State AIDS Control Society. The hours, the location were all provided by the communities. And so by getting buy-in from these multiple stakeholders, you can actually establish such models. And so I want to just end by thanking the research participants, especially my teams from Johns Hopkins, from YRG Care, the National AIDS Control Organization, the various state AIDS control societies, the community-based organizations who really are the heart of the response, especially if you're trying to make impact at the community level, the various funding services. And I want to end with a picture of the Blue Shed. So when we went there in 2018, this was a place that was associated with hopelessness and despair, but I'm hoping that through the Blue Shed project, we're able to transform that into a vision of hope and hopefully a model for the rest of the world to follow. Thank you again for the invitation, and thank you for your attention.